Hello, good afternoon. Welcome to all of you to the next topic in the Venkat Academy web lecture series. As you are aware, we do this every Wednesday. This is as per the syllabus of Aesthetic Dermatology Postdoctoral Fellowship by Rajiv Gandhi University of Health Sciences syllabus. The idea is to teach aesthetic dermatology in a systematic and scientific way. And today's topic is an approach to management of post-acne scars, a very important and practical topic which we face in day-to-day practice. And to talk about this in detail is our own Dr. Suvigya, who is our fellowship student. And to offer his expert comments and to answer all questions, we have Dr. Salim, one of the foremost authorities in cutaneous surgery in India. He has been president of Kerala branch. He has been organizing very important conferences, including the DASIL's World Congress of Dermatosurgery in Goa in 2019. He is also the chairman of Assembly of National Societies in DASIL. And he is going to organize the next Oxycon in Wayanad in September this year. He has done several innovative management techniques in acne, including dermal grafts, enzymatic grafts, etc. So it's a pleasure to have him. He has written on this chapter in ACSA textbook of cutaneous surgery also. So he is a very apt expert for this. So now I hand over the mic to Gloderma team for their customary announcements, followed by the presentation by Dr. Savika. Thank you.
Thank you so much, sir. Once again, welcoming you all for Venkat Lecture Web Academy series on behalf of Venkat Center and Glow Derma. The Venkat Academy Web Lecture series, an educational initiative under guidance of Dr. Venkatram Mysore, the director of Venkat Center, the Center of Advanced Dermatology and Postgraduate Training, Bangalore. So far, we have conducted a successful 16 lectures of Venkat Academy Web Lecture Series with a live attendance of average 750 live audience. And today we will shortly be starting with our lecture 17. And as sir has already mentioned, today we have expert Dr. T. Salim and presenter Dr. Suvigya Sachan. I welcome both doctors on behalf of Venkat Center and Glow Derma. And to just brief you about my organization, Glow Derma, spreading glow in lives of millions with path-breaking innovative technologies. Glow Derma has pan-India presence and we ranked among top 150 pharma companies with an enterprising team of more than 500 professionals. And we have launched many first-time in India brands which are trusted by dermatologists across India. Also, Glow Derma is India's first pharmaceutical company to make all products paraben-free, sulfate-free and detergent-free, because at Glow Derma, we believe patient safety is of paramount concern. This is our Glow Derma journey from domestic operations to international tie-ups. Recently, we have joined hands with Managed Order Cosmetics, which is based in Germany, and we have launched a Sesion Baby, which is a premium skincare brand and trusted by mothers all over the world. And Sesion Baby, all products are made in Germany and they are centered around two natural active ingredients, which are hydrolyzed milk protein and organic olive oil. This is the Sesion Baby Skin Care range, which is quality made in Germany, and all products are Dermatist certified and clinically tested. And the entire range comprises of the cleansing range, which includes a soap, bath and shampoo, skin care range, which have moisturizer, cream, lotion and oil, and diaper care range, including a sun protection cream. Also mentioning about our flagship brand, which is Moist. So Moist LMF 48 lotion, which is a long-lasting moisturizer, exclusively formulated with 17 powerful moisturizing agents and proven to hydrate skin up to 48 hours. Also, we have India's first sulfate-free and paraben-free cleanser, which is Moist Cleansing Lotion, which is extra gentle cleanser for face and body with Derma Neutral pH 5.6. And a persistent skin moisturizer for psoriasis and xerotic eczema, which is Moist Excel Cream with the synergy of 13 most powerful agents. The introducing your entire range of moist family, the most advanced moisturizers and cleansers. I would like to extend gratitude and thank all doctors for your tremendous support to Moist and Glow Derma through your prescriptions. And few instructions to all the delegates. You can download your e-certificate of participation for this lecture by attending a quiz of 10 MCQs and submit your MCQs, and you can download your e-certificate, which looks like this. Also, the recorded version of today's lecture, that is lecture 17, and all previous lecture is available on glowdermadigiConnect.com, which is the same website we have connected right now. And also it is available on Glow Derma official website. Thank you so much. Now I may hand over the session to Dr. Suvigya. Dr. Suvigya, over to you.
Good afternoon, everybody. Today I will be speaking on approach to management of acne scars. Hello.
Yes, madam.
Go ahead, please.
Go ahead, please. You can share and click it.
Actually, my slides are not moving.
Not visible to you?
Just 1 minute.
Yeah, please.
My slides are visible?
Okay.
Yeah, it's visible. Go ahead.
Yeah.
Okay. Yes, sir. As we all know, one of the most common stigmata of acne is the scars, which can play havoc with the social functioning of the patient, leading to severe psychological depression. Acne scarring patients are reported to have greater levels of stress and anxiety than other medical conditions. So, the pathogenesis of acne scarring, injury to the normal skin initiates a cascade of wound healing events, which are like inflammation, granulation tissue formation, and then matrix remodeling. So, the acne scars result from aberrant response to wound healing at various stages. So, first we will see about first stage, that is inflammation. In this stage, proliferation of Propionibacterium acne leads to the stimulation of innate immune response and activation of complement pathway leading to inflammation. Scar correlates to the extent and depth of inflammation. When the inflammation extends significantly into the dermis, resulting degradation of dermal matrix is much more extensive, hence a greater potential for scarring. Initial vasoconstriction is followed by vasodilation and erythema. Melanogenesis is also stimulated at this step. This step is important for development of post-acne erythema and hyperpigmentation. The second stage is the granulation tissue formation. Here, new skin composition in a normal wound is dominated by type 3 collagen with a smaller percentage, that is 20% of type 1 collagen. There is a shift in the balance of collagen type in matured scars to be similar to that of unwounded skin with 80% of type 1 collagen. The third stage is the matrix remodeling. Matrix metalloproteinases are extracellular matrix degrading enzymes that interact and form a lytic cascade for remodeling of the ECM. Activation of this NF-kappa beta and activator protein 1 leads to upregulation of matrix metalloproteinases like metalloproteinases 1, 8, 9, and 30. Each of these are involved in degradation of collagen. Prolonged cycles of upregulation of matrix metalloproteinases and subsequent pro-collagen synthesis are prolonged in acne scar-prone patients. There is an imbalance in the ratio of matrix metalloproteinases to tissue inhibitors of matrix metalloproteinases results in the development of atrophic or hypertrophic scars. So as I have already told, this activator protein 1 and NF-kappa beta, the activator protein 1 will release the matrix metalloproteinases, and there will be prolonged upregulation of this matrix metalloproteinases causing dermal matrix degradation. Also, the NF-kappa beta will release some cytokines like TNF, interleukin 1, interleukin 8. They will recruit neutrophils, and both will cause impaired repair and increase pro-collagen, which will result in acne scarring. So, a classification, the morphological types of acne scars are divided into three: macular, depressed, and elevated. Macular are further divided into erythematous, hyperpigmented, and hypopigmented. Depressed is divided into ice-pick scars, box scars, rolling, linear, and lipoatrophic. Elevated is divided into hypertrophic, keloidal, papular, bridging scars, and sinus tracts. So this is a diagrammatic representation of depressed scars. Like the V shape is ice pick, the rounded with the fibrotic bands is the rolling scar, and this one is the box scar. So now we'll see all types of scars in details. First one, macular scars. Though these lesions are macules and not strictly scars, they are so called because they tend to persist for months. First one is erythematous. They are seen following resolution of inflammatory acne lesions, more common in lighter skin and tend to persist in patients that have sensitive skin. They give the impression of active acne lesions. Second one is hyperpigmented variety. In this, it occurs due to post-inflammatory hyperpigmentation. They are very persistent and more common in dark skin patients and those patients who constantly pick at their lesions, that is acne excoriae. And third one is the hypopigmented variety. They are very rare. So now we'll see depressed scars. First one, ice-pick scars. Ice-pick scars are one of the most common scars seen in acne, most difficult to be treated. They are deep, narrow, and sharply defined epithelial tracts that extend vertically to the deep dermis or subcutaneous tissue. Surface opening is wider than the deeper portion as it tapers into V shape, and they appear as if the skin has been pricked with an ice pick. Ice pick is the name of the instrument with a tapering sharp point, as we can see in this image. And these are multiple ice pick scars. Mostly these are seen on cheeks, glabellar region, and nose. Depth of ice pick scars is often below that can be reached with the skin surfacing options like dermabrasion or lasers. Hence, they are difficult to eliminate entirely by resurfacing, as you can see in this diagram. And as they are not distensible, fillers are also not successful. On the contrary, they tend to become more prominent following fillers due to filling of surrounding more elastic tissue. So for treatment of these types of scar, we can go for cross technique, that is chemical reconstruction of skin scars, subcision, mini punch elevation or mini punch grafting, microneedling, point beam ablative CO2 or erbium YAG laser. The best treatment for it is combination of cross technique followed by subcision and microneedling. The second variety is box scars. They are round, oval or irregular, sharply defined scars with vertical edges similar to varicella scars. They are called box scars because on cross section they appear sharply punched out like a box scar, which is a wagon of good strain. They are wider at the surface than the ice pick scars, appear punched out and do not taper to a point at the base. As you can see in this photograph, multiple box scars. So they are further divided into shallow and deep. Shallow ones have depth of 0.1 to 0.5 mm. Deeper ones have depth more than 0.5 mm. and most commonly they are seen on temples and cheeks. Shallow box scars are within the dermal reach of skin resurfacing treatments such as laser resurfacing, but deeper box scars are resistant to the improvement by resurfacing alone and require treatment of the full thickness of the scars. So for shallow scars, treatment options: subcision followed by fillers or autologous fat, microneedling followed by resurfacing by spot microdermabrasion or ablative fractional laser or fractional radiofrequency. Subcision combined with microneedling is a useful minimally invasive technique, particularly if lasers are not available. For deep scars, treatment options: subcision, punch elevation, punch excision, and suturing or grafting, followed by resurfacing. Important point is these scars should not be treated with cross technique, as they usually worsen and become more prominent after cross. Next one is rolling scars. They are wide, undulating scars with relatively normal appearing overlying skin. They occur due to dermal tethering of epidermis and dermis to the underlying subcutis, leading to superficial shadowing and a rolling or undulating appearance. Most common on the lower cheeks and mandibular area and worsen with age. Treatment: best treated by combination of subcision followed by fillers or fat transfer. Other options like subcision combined with microneedling, subcision with fractional resurfacing with either CO2 or erbium YAG laser. Next are linear scars. They appear as linear atrophic lines that are commonly hypopigmented with relatively normal skin in between. They may be narrow linear scars where they appear as thin lines connecting each other, or broad linear scars appearing as wider linear dermal depressions. They result from volume loss in dermis or subcutaneous tissue and commonly seen on cheeks but also seen in glabellar region, as you can see in this image. So for treatment, method of choice for narrow linear scars is subcision, and it is followed by non-ablative laser resurfacing. Another treatment is microneedling. Skin should be adequately stretched while doing microneedling to reach the bottom of the scars, and treatment has to be repeated every 2 to 4 weeks. Next are lipoatrophic scars. These scars occur following resolution of cystic acne, which destroys the fat. Most common in males with a thin asthenic face, giving face a gaunt appearance. More common in lower cheeks, parallel to the nasolabial folds. So treatment: if the epidermis is relatively normal, subcision followed by fillers or autologous fat can be given. Non-ablative resurfacing with the 15-40 nanometer erbium glass laser can be done. If the epidermis is atrophic, then excision of the scar along the relaxed skin tension lines followed by suturing to be done. Multiple linear scars, then ablative fractional resurfacing can be done with CO2 laser. And for deep lipotrophic scars, fat grafting is the method of choice, and even volumizing fillers can be used. The next are papular scars. These scars appear as raised, hypopigmented and papular lesions, most commonly seen on back, chin and nose. And they result from destruction of collagen and elastic fibers in the dermal tissues around the hair follicles. They are misnamed because they are not actually papules, but appear as soft, elevated lesions like anatodermas. So they should be differentiated from true hypertrophic scars, which are also elevated. This can be done by stretching the skin. Papular scars will get effaced and disappear, whereas true hypertrophic scars remain elevated, and they are one of the most difficult scars to be treated. So no ideal treatment for papular scars, and usually a multi-modality approach is required. Intralesional radiofrequency and non-ablative lasers are most frequently used. Next are hypertrophic scars. Elevated scars are less common after acne. The first is hypertrophic scars. They are elevated, dome-shaped, fibrotic scars, skin-colored or hyperpigmented, frequently seen in the mandibular area of the face and back. More common in males and in darker skin types, and they remain localized and do not extend beyond the surface of the acne lesions. Next one are keloidal scars. These are keloids developing in acne lesions which extend beyond the original acne lesions. They have irregular borders and are often symptomatic, causing itching or pain. seen more often in males on back, shoulders, and chest. So for treatment of these, intralesional steroids can be given, cryotherapy, silicone gel in sheets can be used, radiofrequency ablation, lasers like pulse dye laser for early scars, and CO2 laser ablation can be done for older lesions. Next are bridging scars and sinus tracts. They occur following healing of severe acne. These are channels joined together by epithelial tracts overlying normal or atrophic skin. They often contain foul-smelling products of sebum and cause great distress. So treatment best method is to excise the tracts, evacuate the contents, and completely excise the scar tissue. And this is followed by suturing along the relaxed skin tension lines. So there is scaling, that is global acne qualitative scale, Goodman-Barron. They've divided it into 4 types. Grade 1, where macular scarring is there without textural changes. Grade 2, mild atrophy or hypertrophic scarring is present that is not evident at 50 centimeter and masked by makeup. Grade 3, moderate atrophic or hypertrophic scarring, obvious at social distances and not easily masked, but can be flattened by stretching. And grade 4, severe atrophic or hypertrophic scarring that cannot be flattened with stretching. So for grade 1, patients can expect improvement around 100%, grade 2, 80%, grade 3, 70%, and for grade 4, improvement 60%. Another scoring is that is quantitative scale of Goodman-Barron. Here, for different grades, depending on the number of lesions, they have given different points, and this grading is used for research purpose. So now we will see different methods of treatment for acne scars in details. First one, TCA cross. As we all know, like 100% TCA is applied on the ice pick scars with the help of sharpened wooden toothpicks. The principle, it causes precipitation of proteins and coagulative necrosis of cells in epidermis and necrosis of collagen in papillary to upper reticular dermis, causing increased collagen production and dermal collagen remodeling. So the complications of this procedure, it can cause post-inflammatory hyperpigmentation, worsening of the ice pick scar if the TCA spills to the surrounding normal skin. Premature removal of the crust can also cause suboptimal collagenization or worsening, as you can see in this image. So to prevent the spillage, and sometimes the thickness, the diameter of the wooden stick which is used is more than the depth of the ice pick scar. So one modification was done, that is 27 gauge tuberculin syringe was used to apply TCA for ice pick scars. It helped to assess the bottom of the ice pick scars. Fluid drop outside the syringe formed a globule due to the surface tension dynamics. An amount of TCA can be easily controlled with the plunger. Also, the spill of acid was minimum. But in this technique also, in many cases, there was spillage of the TCA to the surrounding areas when the plunger was pushed. So one more modification was done, that is TCA cross air column inside insulin syringe method. In this modification, because of the air column, very small amount of TCA is expelled out each time the plunger is pushed. Next is subcision. Subcision, as we all know, it involves undermining of the depressed acne scars and releasing the scar from the underlying fibrous tissue. Procedure produces a collection of blood under the defect. Blood acts as a spacer, keeping the scar base from the immediately reattaching to the surface layers. An organization of this blood clot is thought to induce longer term correction by the formation of collagen. So subcision is done usually by a hypodermic needle, that is 18 gauge needle or a NOCA needle. But when the needle is introduced straight, there is a risk of going deeper or penetrating the skin superficially. So to prevent this, 2 modifications have been done. First one, the needle is bent at right angle, as you can see in the image, at the bevel or slightly higher with the help of sterile artery forceps, and then introduced in the skin. In this way, insertion is quick and in the same plane is preserved in the dermis, parallel to the skin surface. Another modification, needle is again bent at the right angles and mounted on the syringe. And this, as you can see in this image, with this technique, the procedure becomes much more comfortable. Another modification was done, like when we do subcision, there a lot of blood comes out from the back of the needle. So another modification, that using sterile cotton and cyanoacrylate glue was used to plug the needle hub during subcision for a bloodless field. The complications of this procedure: hematoma, nodule, but these usually subside in 1 to 2 weeks. Next, punch excision. This technique is used for the treatment of deep, depressed and large acne scars. A principle of this technique is to replace a prominent scar with a less obvious scar, useful when the depth of scar is more than what we can safely treat it with resurfacing techniques, that is deep reticular dermis. So different sizes of punches are used according to the size of the scars, and then they are sutured. One more technique, that is punch replacement grafting. If the scars are close to each other, surface and texture is atrophic and less than 4 mm in diameter, they are excised and replaced by punch grafts taken from either post-auricular area or buttock. And care should be taken that they fit snugly fit at the surface. One modification of punch grafting, that is abraded punch grafting. In this technique, the epidermis at the donor site is first abraded with a derma abrader. Then punch grafts of the required size are harvested. In the recipient area, the entire affected area of the acne scar is abraded. Then abraded donor grafts are then placed in the recipient punched out sites. So the advantages of this technique is better color matching, as regenerating epidermis covers the grafted site and the area in between uniformly. And the reduced chances of cobblestoning and the ring scar formation. And also duration of treatment is shortened. So next method is the punch elevation. If overlying skin is relatively normal, an appropriate size punch that exactly fits into the scar is selected and introduced up to the subcutaneous tissue. A sudden give will be felt once the subcutaneous tissue is reached. An excised punch is raised to the surface without cutting at the base. And it should be neither raised nor depressed. It should be at the level of surface, and steri strips or cyanoacrylate glue can be used. So the complications of this punch techniques are: if the graft is too small, it will get depressed, causing ring-shaped scars, as you can see in this photo. If the graft size is more, then it can pop up, causing cobblestoning, or it can cause color or texture mismatch. Next is microneedling. It involves use of handheld rolling instrument with tiny needles which create multiple superficial puncture wounds in the skin. And it is done usually with derma roller or with derma stamping. Depending on the length of the needles penetrate into the dermis and initiate complex chemical cascade, including numerous growth factors, resulting in invasion of fibroblasts, leading to more collagen production and collagen remodeling. So the indications of microneedling could be done in grade 2 and 3 box scars, rolling scars, linear atrophic scars. And microneedling can be alternative to laser resurfacing. It is a useful technique in the patient, those who are prone to post-inflammatory hyperpigmentation. As in lasers, risk of PIH is higher because of more heat generated. So the limitations of this technique: minimal improvement has been seen with microneedling if it is performed in ice-pick scars and grade 4 acne scars, and old fibrous scars may not show good response. The next is microdermabrasion, most effective with superficial skin conditions because it produces a superficial depth of injury. Used to treat superficial acne scars, suction pressure is adjusted as desired, handpiece is moved over the treatment area in single smooth stroke, and thicker skin areas, forehead, chin and nose can be treated more aggressively. So the desired endpoint of this treatment is erythema, and for acne scars can be focally treated more aggressively with additional passes. The treatment session lasts for 15 to 20 minutes for full face. Next is dermal grafting. This dermal grafting is effective as a filler material for treating depressed scars This technique builds on previous subcision consisting of placing the dermal grafts into the precise pockets under the skin. As you can see in this diagram, and dermal graft is a skin graft from which epidermis and subcutaneous fat has been removed. So the advantages of this dermal graft, not susceptible to infection, can be accurately tailored for a variety of defects, creates a permanent spacer between overlying skin and underlying fibrous bands of tissue, readily available material and easy to perform. Chemical peeling. Superficial peels are used for superficial acne scars only. There are different peeling agents which have been used for acne scars like salicylic acid, TCS 10%, 15%, 25%, glycolic acid 25 to 35%, and Jessner's peel. And amongst all the peels, salicylic acid peel is both useful for active acne as well as for superficial acne scars. TCA 35% can cause medium depth peeling, hence can be used for deeper scars, but should be used with great caution in Indian skin due to higher chances of PIH. Next, soft tissue augmentation by fillers. It is indicated for treatment of soft atrophic acne scars with loss of dermal tissue. Dermal fillers placed under the scars elevate them, bring the surface of the scars in level with the surface of surrounding skin, and all types of fillers from temporary to permanent like hyaluronic acid, polyl lactic acid, calcium hydroxyapatite, liquid injectable silicones, autologous fat have been used. And these fillers have advantage like it will give instant results. So next technique is scar revision. In selected cases, when scarring is linear and extensive, scar revision techniques like ZM and Y-plasty can be useful, but they need to be performed by dermatosurgeon who is properly trained in performing these procedures. Now we'll see about different laser treatment in acne scars. So the ideal candidates for laser treatment are from grade 2 to grade 4 scars. Rolling and superficial box scars responds best. Grade 4 scars are the most difficult to treat and generally do not show much improvement after single treatment. First one, ablative lasers. They cause ablation of epidermis and part of the dermis with resultant collagen deposition as a part of healing response. Two main types of laser used ablative is a CO2 laser and erbium YAG laser. CO2 lasers are more ablative and cause vaporization of the epidermis and papillary dermis to a depth of around 50 to 150 micrometer. And erbium YAG laser, the depth of ablation with this laser is less than with the CO2, cause minimal surrounding thermal damage also of 5 to 15 micrometer. But the depth of ablation can be increased by increasing number of laser passes, and even the extent of surrounding thermal damage can be increased by increasing the laser pulse duration. Non-ablative lasers, they cause induction of controlled injury to the dermal collagen without any damage to epidermis, and it leads to a healing response with dermal collagen remodeling. This causes tightening effect on the skin with resulting improvement in appearance of scars. So they are divided into infrared lasers like 1450 nanometer diode laser, 1064 nanometer Q-switch ND-YAG lasers, 1320 nanometer ND-YAG laser, and 1540 nanometer erbium glass laser. Another the group is the visible light lasers. They include intense pulse dye lasers, light emitting diodes, and broadband light sources. The treatment with non-ablative lasers can provide modest improvement in acne scars, and they also require multiple sessions at an interval of 3 to 4 weeks. Next, fractional photothermolysis. Fractional means only a fraction of whole skin is treated rather than the whole skin surface. And this fractionated treatment minimizes the chances of any serious adverse effects to the skin and also shortens the downtime after treatment. The technology provides a fine balance between the undesirable side effects of ablative laser and the limited efficacy of non-ablative ones. So the non-ablative fractional resurfacing, the fractional lasers with a wavelength in the range of 1410 to 1550 nanometers are used. They cause columns of cognitive change in the dermis without injuring the epidermis, and most commonly used once is the 1550 nanometer erbium doped fiber laser known as Fraxel laser. Most of the studies reported improvement in scar appearance in the range of 50 to even 75% after multiple sessions at monthly intervals, and they cause minimal downtime and are considered safer than ablative lasers. Next are ablative fractional lasers. They provide ablative laser technology in fractionated pattern that gives the efficacy of ablative laser treatment but minimizes the side effects of ablation. These cause a direct vaporizing effect on the epidermis and some part of dermis in microscopic columnar pattern. And in addition, there is a zone of coagulation of variable thickness around these columns. So here also fractional CO2 and fractional erbium YAG lasers are used. So the adverse effect of this fractional laser resurfacing, erythema and crusting, PIH, acne flare-up, pruritus, bronzing, and sometimes like purpura, prolonged erythema, aggravation of scarring and hypopigmentation can be seen. Next is MNRF, microneedling radiofrequency. It is a fractional resurfacing technique for the treatment of acne scars. It creates controlled thermal damage in the dermis and stimulates wound healing response, thus initiating a collagen remodeling process by using thermal production from tissue impedance and subsequent heat diffusion to deeper tissues. So the needle depths range from 0.5 mm to 3.5 mm and is modified depending on the anatomical site and the pass number. And the power levels are adjusted according to the needle depth and size. Exposure time ranges from 10 milliseconds to 1000 milliseconds and procedure is repeated in every 4 to 6 weeks. So these MNRF creates a pyramidal injury zone unlike the conical thermal damage induced by ablative lasers and greater depth of penetration of microneedles as compared to fractional laser. Insulated microneedles coagulate only the deeper part and protects the epidermis, but it is associated with bleeding. And the uninsulated microneedle cause coagulation along the full length of needle, thus preventing microbleeding. So the advantages of MNRF: less epidermal disruption, only 5% as compared to 10 to 70% with the fractional ablative laser system, faster healing process, less chance of PIS, minimal downtime, and control over the depth of treatment. Another technology that is this is the TIGSIL. It is a non-laser fractional treatment device based on thermomechanical ablation technology, similar in effectiveness to fractional CO2 laser, and the energy is emitted through matrix of 81 tiny pyramid-shaped pins made up of biocompatible material covering a treatment area of 1 centimeter square, heated to a temperature of 400 Celsius. During treatment, pins are introduced to the surface of skin at a precisely controlled speed, after which the thermal energy stored in the pins is transferred upon the brief contact with the skin. And it causes vaporization from the skin instantaneously, resulting in formation of tiny craters, as you can see in this image. So the advantages of this TIGSIL: extremely high control over the diameter and depth of craters, which are as deep as CO2 but narrower, less charring and crusting, safe to use with darker skin tones, lesser pain without anesthesia or cooling, and less downtime and post-care. Role of PRP in acne scars: as we know that the PRP contains many beneficial growth factors which promote collagen and elastin regeneration. It is found helpful in box scars and rolling scars, but shows limited efficacy in ice-pick scars. And more studies have shown a synergistic effect when PRP is combined with other modalities. Bhargava et al. Reported PRP can decrease the downtime associated with other modalities. However, studies done by Fagihi et al. And Ibrahim et al. Showed that there is no advantage in adding PRP to fractional CO2 or needling. Another method is the fat transplantation. It is indicated for severely atrophic scars in which there is destruction of deeper tissues. Liposuction is performed from a viable donor site and the fat removed is then injected into the atrophic scar, and it is advisable to perform the subcision first. So the advantages of scars and texture: studies reported more effective than ablative fractional CO2 laser, no downtime, Disadvantage, some fat may not survive the transfer process. Procedure is operator dependent and longevity of the correction is doubtful. Recent one is the picosecond 755 nanometer Alexandrite laser. And histologic findings indicate improvement in scarring, which is beyond collagen remodeling. Also, there is additional improvement in pigmentation and texture of the surrounding skin, and it has been used for rolling scars. Botulinum toxin, severely atrophic grade 3 acne scars can be aggravated by normal muscle movement. So several authors find that botulinum toxin can be beneficial if the acne scars are present on forehead, glabella, and chin. RF for papular scars, same time making the scar less visible. The power of RF machine should be minimal and scar is approached perpendicularly and the wire electrode is inserted up to a depth of deep dermis. But because of this RF, it frequently leads to PIH and scarring. So one modification was done that intralesional radio insert into the depth of papular scar and the tip of the RF probe is touched onto the needle. So the principles of prevention of acne scars. So different principles, like first important thing is treat the acne as soon as it develops, avoid inflammation, treat inflammatory lesions early, treat severe acne aggressively, treat patients prone to hyperpigmentation carefully, and advise patients not to squeeze the lesions. The current trend for acne scars, as I've already told now, minimally invasive techniques and combining procedures are important. Priming to be done for all the patients of acne scars, both with topical and systemic treatment. Topical like sunscreen, skin lightening agents can be given, anti-acne agents like retinoids can be given, and treat active acne according to the severity. Avoid procedures So it is important to first evaluate by taking history, examining the activity of acne, comorbidities, type and severity of acne scars, counsel the patient and know their expectations, alignment, timeline, cost. Tell the patients about the downtime and the complications of procedure. Plan according to the prominent scars, type, severity, combination, treatment, and facilities available, and execute the knowledge, practice, equipment, facilities, priming, pre and post care. So in conclusion, treating acne scars requires a targeted multimodality approach. Techniques depend on individual type of scar, and targeted approach combining treatments gives optimal results. Thank you.
Yeah, thank you very much, Dr. Subhigya.
Thank you, sir.
You have almost covered almost all procedural management in acne, not just surgical alone, but definitely you require everything, because acne scar management is always a combination. And something before we go on to the questions, what I would suggest, here's like before you take up a case for a surgical management or any other procedural management, it would be better if you do a stretch test. You just stretch the skin and see if the scar is improving, then these would be cases which you could be managed well with a resurfacing technique, either the lasers or your microneedling, or to a certain extent with the subcision, if you do a subcision at two different levels, like the superficial scar as well as a deeper subcision as well. So this is what you need to know as some of the basics when you start treating a acne scar. And majority of the things I think was covered there. And because acne scar, the advantage of the surgical management is that most of this surgical management techniques are cost effective, and which could be managed at a peripheral settings as well, even if you don't have an energy-based device. So your microneedlings could be done, your subcision at different levels could be done, and some of your deepithelialized dermal grafts and things like that, and basic excisions like your punch excisions, punch replacement, and linear excisions could be done. Everything at your peripheral settings without, and your TCA crosses and rest of the things as well. So even without many of your like energy-based devices, acne scars could be treated. Any comments from Venkat sir?
Yeah, thank you, Surya. That was a fairly extensive coverage. Now we'll hear from Dr. Salim. Salim, now if you see as you rightly said, the treatments can be classified into those who have the devices and those who don't have the energy-based devices. Now, if there are no devices in a little resource-poor setting, if there is a case of severe scarring, how do you suggest that it should be managed? Mild scarring, I agree, it is not that difficult. But a severe scarring, what all would you like to do if you don't have access to lasers and MNRF?
Right. Here, what I would suggest is that the subcision is something which is a very underutilized technique among our dermatologists, actually. So it's not just the simple subcision of your simple scars alone. You have something called a bi-level subcision or a multi-level subcision. So in the bi-level subcision, what you do is like you do a complete full plane subcision. There are few papers. The initial papers were from forgotten. Yeah, there was an initial paper they have done with large cannula subcision, and we have also done a lot of cannula subcision where we have deplaned the whole area. Along with that, we have also treated the superficial scars with the kind of subcision which Subhigi has already mentioned here. So that would give an overall tightening of the face as well as improvement in the scars. Similarly, if you have the box scars, I mean the box scars and larger scars or the linear scars, you can do excisions as well as a punch excision. All these things could be definitely done at a peripheral setting. Even the ice pick scars, the best possible option is again a TCA cross, which could be definitely done at this particular level. If there are more superficial scars for a resurfacing part, you can again think of your micro needling, simple micro needling. So if you combine all these things, I think you could be able to do a lot more in your basic acne, even if it's a very severe scarring. And again, combining this whole procedure with PRP would be another option to improve the scars in a shorter time.
Subcision, there is a question. Due to hematoma, number one, the hematoma itself can persist for a long time. How to manage that? And that sometimes you can develop pigmentation as a result of that hematoma. How to manage that and how to prevent it also?
See, basically, hematoma, we are looking for a bleeding in this particular plane. That is why we are doing a subcision. So if you have a lot more of hematoma, if you have gone to a different plane, or if it is cosmetically disfiguring or something like a black eye you're given, definitely the simplest option would be giving the heparin creams, the gels available, that is the thrombophobe sort of a gel in the initial phases. Otherwise, some amount of hematoma we expect, and that will resolve by itself. So if there is any hyperpigmentation which is come because of this thing, I mean your subcision, that usually it subsides. You could again give something to reduce your, like what you treat, how you treat your post-inflammatory pigmentation. You can use some of your depigmenting agents and things like that if it is persisting for a very long time. But if it's an acute one, best thing would be if you find it very difficult, then you can use something like your topical agents like your heparin agents. And if there is a large hematoma which is there, you can definitely puncture it, and you can definitely take it out.
Yeah. See, we use arnica after bruising after fillers. I do not know whether anybody has used arnica after subcision.
Yeah, definitely.
Have you?
Arnica could be used. Yeah. No, I haven't used it.
Okay.
I have used a thrombophobe gel many a times,
Yeah.
because when we go do quite close to your eyes, even when you do some of the excisions, you start getting these sort of large, black eye sort of lesions. There we use more of heparin creams.
Thank you. See, amongst all the procedures, this subcision is the one which can cause some pain as well as some take some time to heal. So a lot of counseling is needed while it is being done, because we generally like to tell patients that these are all simple procedures, lunchtime, weekend procedures, but sometimes the hematoma can persist for 5 to 6 days. So counseling is very important. And the pigmentation, if it happens, it is partly due to hemosiderin, which will take its own time. So that is one thing to be kept in mind. And I generally don't like to do subcision as the first procedure for a patient. I would like to do it after 1 or 2 visits when the patient has got accustomed to the different procedures. Okay, now let us see some more questions are here. All right. Now for subcision, which is better, no-core needle or a simple 18 gauge hypodermic needle, as no-core needle can cause more damage?
Yeah, it is basically, it all depends on your hand actually. Start off with a less traumatic technique initially. When you have known the technique properly, definitely I do prefer a no-core needle over your hypodermic needles, because that gives me a better perception whenever I do this particular procedure. And for the deeper subcision, we always use the cannula. That is again the blunt cannula, bifid or the trifid cannulas.
Yeah, so no-core needle availability is an issue. So simple needle in most cases it suffices. Now there is one more question from Dinesh in Chennai. Is subcision mandatory before MNRF and lasers? And should it be done each time you do lasers, or you do 3-4 subcisions and then proceed with MNRF and lasers?
Not exactly. Basically, it all depends on the kind of patients you are looking for and the type of scars you have. Because acne scar is like, you cannot define as, you cannot have a single like a guideline to go, because each scar is different. The different types of combinations of scars you have. So it is all individualized approach. But for example, I'll tell you, if you have a patient who has only 3 months in your place, if you want to do a lot of procedures, definitely you combine a lot more things together. So you can use your like MNRF or a ablative lasers in the same session itself. You would be doing your subcision as well. So in the same session, you can also use your PRP. So that is to like aggressive management. In a single session, you go with a lot more things so that you can reduce the total time gap between the session. If you have another patient who don't want something so much of downtime, they need only something like a lunchtime procedures or a minimally invasive procedure sort of a thing, then you can go with multiple sessions of lasing or MNRF. Along with, you can do simple subcisions without creating much of an issue. So it is all depending upon the how you want to go ahead and what the patient wants.
Yeah, you're very correct. I agree entirely. This is something I tell my fellows, that each scar you have to study, and that is one scar to be treated in one way. So if you have 5 scars, there may be 5 different ways of treating it. Each scar has to be individualized. So it is not that even if you are using a laser, the type of laser that you use, the setting that you use, the parameter that you use may be different from scar to scar. Now this brings one more question. Salim, now that we have very good, safe fractional lasers and MNRF, which can take care of a lot of types of scars, how much place is left for the the other surgical modes if one has access to these machines? Meaning, if we have laser and a very good MNRF machine, is there still a need for the surgical modalities, or can we just manage with the devices?
Definitely, you can manage with devices a lot of the thing where you really require a resurfacing part. But there are certain scars which are very, very deep scars, and maybe like the interconnecting scars and things like that, where you really require an excision. So in these areas, you might require a simple elliptical excisions or a punch excisions, or so those sort of activity, as well as if there is a lipodystrophy, you need some fat to be placed there, or you need some more volume there, which you cannot create with many of these things, because you might be able to get some tightening with the devices. You might be able to improve the basic scars, but if there is some volume loss, if there are very bad, ugly looking scars, which you cannot be managed with your even the very high-end machines. It is because I work with the ultra pulse CO2, which I work with my burn scars as well. But there are a lot of scars even which we cannot manage with those machines as well. So definitely the surgical management do have a role.
You are correct that even with the best of the machines, there is always some scars which may not respond. There, either a surgical modality or a regenerative modality, such as PRP or a fat replacement or a dermal filler or a above filler may be needed. With all this, of course, we can never treat scars 100%. That is something always to be remembered. There is one question here, and that is, which is better between a fractional ablative laser or MNRF? What would be your preference? Carbon dioxide laser or MNRF?
I would not give you something. Yeah, definitely. I will not tell you, because each has got its own advantages and disadvantages. So it all depends on how good the machine is in your hands. For example, you don't want any superficial injuries, and if the patient really wants to go for work next day, your MNRF works better because it doesn't produce any superficial scarring over there. Whereas when you use a CO2 laser, there are going to be those grit marks and things like that. So the patient will not be able to attend to his regular works for the next 2 to 3 days. So these are the things. But when you come to the results, it's again how you go about and your settings, how you work with the scars and things like that. So I will not say that there is any advantage over one technology over the other, whether it's a CO2 laser or MNRF. Both has got its advantages and disadvantages. What's your take on this, sir?
Say that, see, my take is that if you want a surface resurfacing,
yes,
to improve the superficial texture and appearance, you need an ablative laser. But the MNRF gives you the advantage of going any depth you want. Now, the more recent MNRF machines, you can do whatever depth you can want. You fix it 2.53, 3.54. So that advantage is there without burning the superficial skin. So the advantage would be a combining a surface laser, fractional laser with MNRF to take care of different levels. But where I am of the opinion is the role of fractional laser, carbon dioxide laser has somewhat decreased, because carbon dioxide laser, you needed to go deep. That is done by MNRF in a very precise way. So my personal feeling is a milder laser such as a erbium YAG laser with MNRF which can go deep is perhaps now the best under the circumstances. But of course, there are people who believe in carbon dioxide laser still. That is always there. Okay, now, what about skin repair gels and epidermal growth factors?
Yeah, definitely.
Is there a place for AHA Glow Healing Gel, Regen D, etc.?
Now, I'll not quote the brands, but definitely the epidermal growth factors do have a role in the immediate healing as well as improvement in the scarring as well. So when you do any of those procedure where you have superficial scarring, if you could afford to use epidermal growth factors, definitely it's really good. And even the non-healing ulcers as well, this has been tried.
Okay, then let us see. What procedures can be done if there are active acne still? Can you treat scars and acne simultaneously?
See, there are the light-based devices, for example, the 580 nanometer one, and if there is a for the active acne pulse lights and even the LEDs, these are the things which could definitely work in an active acne. And I don't think if there is severe active acne, you should be focusing up your scarring at that level. Let the acne subside and let's go for the scar management further.
I totally agree. We should treat the active acne first, unless you have one odd acne here and there. And as far as the devices, I agree with you. In addition, the Q switch lasers have that the spectrum mode or the 300 microseconds mode, quasi Q switch lasers, which can act on active acne. NDAG laser can also act on active acne. One question here, erythematous scars sometimes can cause a lot of problems. The red color doesn't go easily. So how do you treat those scars?
Yeah, initially, basically, the best part to start with is like simple silicone-based gel preparations would be the primary medical treatment for these like erythematous scars in the initial phases. The best thing would be to use, if you have a pulse dye laser or a vascular pulse light, that would be the best possible thing to treat these scars otherwise.
Yeah, I agree with you. What we do is also to use a NDAG laser for that, and that works to some extent. Then let us see if there are any more questions. There are quite a few questions here. Okay, how to treat a atrophic scar patient in a patient who has a keloidal tendency? I think this is a good question.
Yes, definitely. Keloidal tendency, in the sense, if the patient has got acne keloidalis over the face, not to treat it. If there is some amount of keloids elsewhere in the body, you can start treating with a very minimal invasive procedures for rest of the scars and see how the healing pattern is. If the healing pattern is fine, if it is not giving any issues, definitely you can do some of the excision and techniques, but never ever go do a large excision on your keloid patient, even if the patient is not having a keloids over their face as well. But definitely you start off with something simple procedures and see how the scars, if it's not scarring, take a informed consent and explain the patient that there might be at least a little, there is a chance for a maybe a hypertrophy later. And if at all it's that, post-operative management is very, very important here. Give a good silicone gel along with post-operative compressions whenever you treat such patients, whatever the scars may be over the face.
I agree. We have rarely seen healing with keloid after any acne scar treatment. I have not seen even a single case. The patient might have had a little keloidal tendency or the mandible or something like that, but on the cheeks, it is extremely rare to get it. So with a proper consent, it should be possible to manage that. But it is a good question, relevant question. Now let us see here, any more question? Now, sometimes after a fractional ablative laser, the grid marks persist for a longer time in some patients, even though they usually go in 3 days, 4 days. Sometimes they persist for 7 days or 8 days. How to avoid and how to manage?
Yeah, actually, that is not a, I mean, grit margins definitely, I mean, if it is a Simple grids, that is fine. Superficial, you can give good, like initially you can give the epidermal growth factor sort of a gels that would really work. You can give a mild steroid with a antibiotic combination post lasing for next 4 to 5 days. It should take off. Another thing what we come across is like not these grid marks, rather than that, if you use wrong parameters, you get this sort of permanent grids where you get hypertrophy of those area where you have done the lasing. So those are the things that are a little difficult to treat actually. You need to again resurface it with different parameters again. But simple grid marks, what you get it immediately after is just like a healing process. You could use a small mild steroid with an antibiotic combination to be applied, as well as your epidermal growth factors.
How do you treat acne flare-ups if they happen during scar management?
I usually, it all depends on a thing. If there is something like, there can be some premenstrual flare-ups which we come across. So there we don't give much of a management. Otherwise, if there is a severe thing, mostly we give a course of antibiotics and some of the non-irritating stuff. If it is, lots of nodulocystic based acne, but if this is something like a simple papillary acne and things like that, we can go for retinoids. That's it.
What about the papillary scars, which are slightly hypertrophic? They are a little difficult to manage. What is your tip for that?
Yes, sir, definitely. That is one of the most difficult because it is not a scar exactly, because like Swiga has already mentioned in her presentation as well. So it's more of elastin. So what you could do is like the intralesional radio frequency with the insulated probes are available. There are companies which comes with these sort of probes with the insulated ones. You can use those things right into the lesion, and you can do that. Similarly, you can use a carbon dioxide laser maybe in a continuous wave mode, and just go into the center of the lesion and ablate it. So these are the two things which we have been trying out, and to certain extent, maybe around to 60 to 70%, we have got excellent results, especially with the intralesional radio frequency technique, where they have the insulated needles rather than the non-insulated ones, which where you use your syringe needle and then ablate it. The insulated needles comes from few companies like the Elman also has got a separate aesthetic kit where they have these insulated needles with a separate probe for that.
Particularly when these papillary scars occur on the nose, that is particularly problematic, because there, even the slightest pigmentation, for example, you mentioned carbon dioxide laser, that slightest pigmentation will look worse than the papillary scar which the patient had. So I think that is where the problem happens. And so we are also a little circumspect, and we don't go full blast in treating such things. So that is, of course, is one of the difficult scars to treat. I agree with that. Right. Now there is one probably last question that we will take. Any suggestion for good fractional lasers?
Are we supposed to say that, sir?
Yeah, you can answer. These are young doctors. They will need some. You can compare the different machines and their parameters if you wish.
Yeah,
you don't have to give a recommendation.
Yeah. It's basically what sort of a machine you really want to work with. For example, when you go for a fractional laser, you need to work on multiple indications. So it's better to go for a standard machine rather than a very cheap technology, and your wattage is also important, because very high-end machines are extremely expensive, even in very senior and in high-end centers, it cannot be maintained well. Whereas a moderate one with a good pliability, it's like you should be able to play around with the parameters and depending upon the kind of scars and aging process where you want to work with. So here you should go for a machine which should be costing somewhere between, I'm not going with the brands, somewhere between maybe around 18 lakhs to around 30 lakhs. You get a lot of good machines. And these are extremely good and much more than for the very high-end machine for acne scars and the aging part. Not for the burn scars, but for the acne scars, this do excellent. They gives excellent results. So I think you should be looking for something like that. And personally, you can definitely approach any of us. We would be able to tell you how to go about and which are the different machines available there. But in a public platform, I don't think it's really nice to give you comments about certain brands rather than going. So definitely anybody could contact me personally and I'll let you know how I feel with different machines.
I agree. In the olden days, when there were only few pioneers were having some machines, even the most expensive laser, if they bought, they could charge and get away with it. Now, with so many people having fractional lasers, nobody is going to pay you more because you have paid more to the company. We can't say, I have paid 50 lakhs, so you give him. No, he will only pay what is necessary for that indication. So that is an important consideration, and there is no real superiority. And none of these machines will last 20 years. Technology keeps changing. So within 4 or 5 years, you will have to buy another machine. So it's not a great idea to invest in a very, very expensive machine. I agree with that. And it also depends upon what other combination you have. So as I said, supposing you have an MNRF machine, then your requirement for a fractional ablative laser is different. If you don't have a MNRF machine, which is much cheaper by the way, MNRF machines are quite much cheaper, then your requirement is different. So all these factors come into the way of deciding how to buy a laser. So I think now with this, we are almost coming to the end of this. Acne scarring is always a very good discussion. One last comment. Isotretinoin, there is no restriction on using isotretinoin. If you are doing procedures, you don't have to wait. This is one of the things Salim and so many others got together and published a landmark paper and also wrote guidelines after that. So you can safely perform all procedures while using isotretinoin. You don't have to stop it for 6 months or 1 year, which used to be the case. So with that remarks, thank you very much, Salim. As usual, your suggestions are very, very apt, very relevant. Thank you so much, Suvigya. You did a good job. It's a very extensive topic, not easy to prepare and cover everything. Thank you so much. And with these remarks, I hand over the mic to Gloderma team. Next will be a session on appropriate management of aging. And I will be chairing that session. Over to Gloderma.
Thank you so much, sir. It was a very wonderful session and very insightful comments from Dr. Salim. And thank you, Dr. Suvigya, for a wonderful lecture. I would request all the delegates to stay tuned for our upcoming next lecture, which is lecture number 18, held on same day on Wednesday on 16 February 2022 at the same time. And once again, reminding all delegates, now they can download their e-certificate of participation by attending the quiz based on today's topic. And this is their certificate of today's lecture. Please note, all of you, the recorded version of today's lecture and all previous lectures are available on the same website, that is gloderma.digiconnect.com. Also, it is available on Gloderma's official website. And requesting once again and reminding all of you about Sanosin Baby Skincare range and our Moise flagship brand, which is a family of most advanced moisturizers and cleansers. So please be connected with us and with your valuable support to Moise and Sanosin. Thank you so much and wishing you all a good day and good health. Thank you so much, sir.
Thank you so much. All the best.
Thank you, sir. Pawan, stop recording. Pawan?